Hi guys, it's me, Antiplatelet Agents. Some of you already know that there are two of us. To those who are new and unaware of the situation, here it is. I have two personalities, and we have decided again that I will present first and the other me will take over after my discussion. So let's start. My name again is Antiplatelet Agent. I am known as a platelet agglutination inhibitor or platelet aggregation inhibitor. I'm also a member of class pharmaceuticals that decreases platelet aggregation and inhibits thrombus formation. I'm effective in arterial circulation where anticoagulants have little effect. Now, let's talk about my drug name. First, my generic name is acetylsalicylic acid P2Y12 receptor antagonist glycoprotein 2 beta or 3 alpha inhibitors. My brand names are acetylsalicylic acid, the brand name of aspirin, asafen, and trophinovacin, clopidogrel with the brand name of Plavix, prasugrel with the brand name of Efient, and ticagrelor with the brand name of Brilinta. Let's talk about my drug classification. First, my therapeutic drug classifications are platelet agglutination inhibitor or platelet aggregation inhibitor, irreversible cyclooxygenase inhibitor, adenosine diphosphate receptor inhibitor, phosphodiesterase inhibitor, protease activated receptor 1 antagonist, glycoprotein 2 beta or 3 alpha inhibitors, adenosine reuptake inhibitor, and thromboxane inhibitor. Next is my pharmacologic drug classification is antiplatelet agent or antiplatelet drug. My pregnancy category is C. Here, I may cause teratogenicity and fatal toxicity, and perinatal mortality is increased. However, when low doses are administered as antiplatelet therapy, treatment is relatively safe. Now let's talk about my mechanism of action. It is possible to identify antiplatelets based on the mechanism of action as follows. First, inhibitors of platelet aggregation such as aspirin and similar inhibitors of cyclooxygenase. It works by irreversibly inhibiting the cyclooxygenase enzyme activity in the prostaglandin synthesis pathway. This prostaglandin is a precursor of thromboxane A2 and PG12. Thromboxane A2 works by inducing platelet aggregation and vasoconstriction, and COX1 inhibits its production while PG12 works by inhibiting platelet aggregation and induces vasodilation and is inhibited by COX2. Low dose of aspirin, like 75 mg to 150 mg, can induce complete or near complete inhibition of COX1, which inhibits the production of TXA2 while larger doses are required to inhibit COX2. Clopidogrel, ticagrelor, ticlopidine, and prasugrel are oral thienopyridines. Oral thienopyridines selectively inhibits adenosine diphosphate-induced platelet aggregation. These drugs convert to an active drug with the help of hepatic CYP450 system that inhibits the platelet P2Y12 receptor. Prasugrel is the most potent of all three drugs and has a rapid onset of action and is superior to clopidogrel in patients undergoing coronary stenting. ticlopidine has fallen out of favor because of bone marrow toxicity. Second, inhibitors of glycoprotein platelets like abciximab, eptifibatide, and tirofiban. Glycoprotein platelet inhibitors function by inhibiting platelet receptors and glycoprotein 2 beta and 3 alpha, therefore minimizing the platelet aggregation, and are most widely used in the acute type of ACS. Third is the antagonist of protease-activated receptor 1 like vorapaxar. Lastly, miscellaneous like dipyridamole and cilostazol. Dipyridamole has antiplatelet and vasodilating effects and inhibits the phosphodiesterase of platelet cyclic nucleotides. On the other hand, cilostazol has vasodilatory, antiplatelet, and antiproliferative effects. It also decreases smooth hyperproliferation of muscle cells and intimal hyperplasia after an endothelium injury. Now let's talk about my pharmacokinetics. In absorption after single and repeated oral doses of 75 mg per day, clopidogrel is rapidly absorbed. Mean peak plasma levels of unchanged clopidogrel occurred approximately 45 minutes after dosing. Absorption is at least 50% based on urinary excretion of clopidogrel metabolites. For aspirin, the volume of distribution is 0.1 to 0.2 liter per kilogram. Acidosis increases to the volume of distribution because of enhancement tissue penetration of salicylates. In distribution, clopidogrel and the main circulating inactive metabolites bind reversibly in vitro to human plasma proteins. The binding is non-saturable in vitro up to concentration of 100 microgram per ml. For aspirin, this drug is distributed to the body tissues shortly after administration. It is known to cross the placenta. The plasma contains high levels of salicylate as well as tissues such as spinal, peritoneal, and synovial fluid, saliva, and milk. In metabolism, clopidogrel is extensively metabolized by the liver. Also, as much as 80% of the therapeutic doses of salicylic acid is metabolized in the liver. In excretion, approximately 50% of total radioactivity was excreted in urine and approximately 46% in feces. After a single oral dose of 45 mg, clopidogrel has a half-life of approximately 6 hours. The elimination half-life of the inactive acid metabolite was 8 hours after single and repeated administration. Covalent binding to platelets accounted for 2% of radiolabel with a half-life of 11 days. I'm done with my part now. Thanks for listening, everyone. It's time to switch with my other self.
Finally, it's my turn again. Hi, I also represent the antiplatelet agents. For our indications, we have been proven to be effective in multiple types of coronary heart disease and secondary prevention after the first ischemic stroke. In these settings, we decrease the risk of myocardial infarction, stroke, and cardiac death. For our contraindications, we are contraindicated to large esophageal varices, recent stroke within 2 years, history of intracranial hemorrhage, significant thrombocytopenia, major surgery within 72 hours, hypersensitivity to the medications, acute clinically significant bleeding, end-stage renal disease on hemodialysis, decompensated liver cirrhosis, severe hypertension with BP over 200/110 mmHg, and congestive heart failure. For our side and adverse effects, we will discuss this by system. For the cardiovascular and circulatory system, we could possibly cause hematuria, hemorrhage, thrombocytopenia, palpitations, and arrhythmia. For the integumentary system, we can cause ecchymosis and peripheral edema. For the respiratory system, we can cause aspirin-induced asthma and ticagrelor-related dyspnea. For the digestive system, we can cause upper gastrointestinal bleeding, diarrhea, and indigestion. For the special senses, we can cause nasal polyps and epistaxis. And for the systemic response, we can cause pain, infection, and upper respiratory symptoms. The nursing responsibilities before drug administration include assessing for mentioned contraindications to the drug in order to prevent potential adverse effects. It is also important to conduct thorough physical assessment before giving drug therapy to establish baseline status, determine the effectivity of therapy, and evaluate potential adverse effects. Another responsibility is to obtain baseline status for complete blood count and clotting studies to determine potential adverse effects. Nursing responsibilities during administration include administering the drug with meals to relieve GI upset. It is also important to provide comfort measures for headache because pain due to headache may decrease patient compliance to treatment regimen. Another responsibility is to educate the patient on ways to promote safety, like using electric razor, soft bristled toothbrush, and cautious movements, because any injury at this point can precipitate bleeding. Another important thing to remember is to educate patient on drug therapy, including drug name, its indications and adverse effects, to enhance patient understanding on drug therapy and promote adherence to drug regimen. The nursing responsibilities after drug administration include monitoring the patient response to therapy. You should also monitor for adverse effects. It is also important to evaluate patient understanding on drug therapy and monitor patient compliance to drug therapy. And just like that, we are all done. I hope you learned a lot from us, and I hope you had fun. I wish to see you next time. Take care!